We are happy to have Matthew Grossman, who graduated from SUNY Stony Brook School of Medicine in 2003 and completed his pediatric residency at Yale New Haven Children's Hospital in 2006. He is an associate professor of pediatrics at the Yale School of Medicine and a pediatric hospitalist. He has been the quality and safety officer for Yale New Haven Children's Hospital since 2013, and his team was awarded both the 2015 and 2017 National Pediatric Quality Award from the Children's Hospital Association for the development of the Eat, Sleep, Console model of care.
So I'm just going to get in. I'm going to get in and talk a little bit about how we developed this approach at Yale now starting about 10 years ago, and how we came about it, how we thought about it, and what we're working from. So obviously, I don't need to tell anyone on this call. Oh, and the other disclosure I have, by the way, is I'm not a neonatologist, as was mentioned below. I'm a pediatric hospitalist, which was part of that was probably helpful in developing this. All right, so obviously there's been a major opioid crisis in the United States. A lot of that led by physician prescribing. Prescriptions grew fourfold over the last decade. In Connecticut, the leading cause of accidental death has always been car accidents. Our car accident rate has remained pretty stable, but now there are 3 times as many opioid deaths in our state each year as our car accident deaths. 2012 is the last time I saw this number. There were enough opioids prescribed to give every adult in the US 1 prescription. And so if you didn't get one, then somebody got yours. So where we have seen the opioid crisis the most in pediatrics is with babies born to moms who are using opioids, either prescribed or otherwise. And you can see these, the numbers have gone up really dramatically from 2000 to about 2016. They're somewhat leveling off at this point, but they really went up about 8-fold over that time. So this was a big change. And one of the issues with this population is really outside of prematurity. This is the longest length of stay we have in anything in pediatrics. So with a big increase like that, a lot of hospitals really felt that. In 2012, kind of in the middle of that, the estimate from this study was that somewhere between 4 and 5% of all NICU beds were filled with babies going through neonatal abstinence syndrome. And in community hospitals, it could be as high as 50%, which is what we see in Connecticut and most of our community hospitals. That's most of what their NICU volume has been kids being treated for neonatal abstinence syndrome and staying on average somewhere between 3 and 4 weeks, which has been the average length of stay for many years for us, which is, again, is so much longer. And particularly as a pediatric hospitalist, our average length of stay is usually about 2 days for most of our cases. And so getting up that high is really quite something. So what happens to the baby? So a baby exposed to opioids in utero, particularly what we see most in Connecticut is methadone. A lot of methadone programs, particularly around our hospital in New Haven. We're seeing a little bit more buprenorphine over the last few years, but methadone is still our dominant exposure. But really, it doesn't matter that much what the exposure is, what type of opioid it is, at least. So what's happening is the fetal brain is being bathed in this opioid. In order to keep a level of homeostasis, there's an upregulation of receptors, mostly in the locus ceruleus, but also in some other areas. And when the baby's born, there's a surge of mostly norepinephrine that seems to coincide well with the withdrawal signs, which are not all that different than what you see in adults, which I'm certainly not an expert of, outside of having seen The Wire and the movie Trainspotting, which is where most of my knowledge of that comes from. Those of you who have cared for these babies will note that this looks very familiar, and this is a version of the modified Finnegan tool. This was developed in the mid-1970s in Philadelphia by Loretta Finnegan and her team during a heroin epidemic in Philadelphia, and they were really being inundated with these babies and didn't have a standardized way to care for these kids. And this is kind of where the modern history of NAS begins, but certainly isn't the beginning of the story. This first shows up in the literature in the 1890s. And this is when one of the prevailing cough medicines was heroin, and laudanum was given to a lot of kids to keep them keep them quiet during the day. So there were reports of it, and most of the reports were really about the high mortality rates for these kids. There would be case studies, and you have 12 kids, and nine of them would have died. There's a review article from the 1950s, which shows that as well. And then as you get into the 60s, and you get methadone being started as a maintenance therapy, medication-assisted treatment, and then really somewhere in the 70s is where neonatal abstinence syndrome term comes into play. And where we get to the modern treatment of this disorder. And so Dr. Finnegan and her team they basically, through observation, were looking at all the signs of withdrawal that you could see. And they split them into these different groups: central nervous system disturbances, metabolic, respiratory disturbances, and gastrointestinal disturbances. And then gave a point value to each one. And there wasn't anything terribly scientific about the point values, just the things that seemed worse got higher scores. And so, for instance, nasal stuffiness gets 1 point, and severe tremors gets 3 points, which makes some sense. And of course, there's a magic number to this. You would do this for this scoring tool. It looks like every 2 hours. Most places will do it somewhere between every 2 and 4 hours. And you add up the scores, and the magic number is usually 8. And so that people should have been saying that along with me. So 8, most places is 3 scores of 8. Some you'll see 2 scores of 8. We would do 3 scores of 8 or 2 scores of 12. I found only a couple of places that have had some variation off of that. And that's pretty much how it's been done. The first line treatment is supposed to be non-pharmacologic care, and then this helps to guide the medication treatment. And so much of the research over the years has been trying to figure out what the right medication or combination of medications are best to treat this. And at Yale, so get a lot of this is going to be our story at Yale. We went through most of them. It looked like in the 70s we were using this, which is paregoric, which I have trouble understanding why this was the choice. This does not look like something you should give to anybody, much less a baby. Paregoric is basically tincture of opium with some additional carcinogenics in it. So it was an odd choice, which we don't really use anymore. And tincture of opium is what we moved to. But tincture of opium is 30% alcohol. So that was a little bit of an issue. But what you'll see in these studies that I have listed on the bottom, the outcomes that most these studies are looking for is either a length of stay in the hospital or length of treatment with whatever medication you're using. And so it's kind of a medium-term outcome. It's not looking at, if you give the medication, what happens to the scores. It's mostly just what is this doing to length of stay. And so this first one is a comparison of morphine and tincture of opium, and didn't find any real difference in length of stay. So we were using tincture of opium through the 80s, and sometime in the 90s, we switched over to morphine, which was just basically a decision from our pharmacy. We stopped carrying tincture of opium. So it wasn't a decision of our providers. This study below is from Scotland, and this compared using morphine as first-line treatment versus phenobarbital. And the AAP guidelines have said basically you should use a like medication. So if you're withdrawing from an opioid, then you should give an opioid back. Phenobarbital is not an opioid. It has some sedative qualities, and there are certainly some concerns for long-term issues if it's used for a long time. But this is a study where it's used as a first-line treatment, as many of you probably have used, more commonly as a second-line treatment. And this is actually a study from Brown in 2002, where they did use it as a second-line treatment and got really dramatic results. So they gave half the kids tincture of opium and half the kids tincture of opium plus phenobarbital. And they found that the group that got phenobarbital had half the length of stay of the other group. So extremely dramatic results. In fact, for those of you who have read Cochrane Review articles, which I have certainly plenty of them, the conclusion seems to always be need more studies. And this was one of the few examples where it didn't say that. It basically said, based on this study, this is probably what people should be doing. So, and that's what we were doing. We were using morphine, and then if we maxed out on our morphine dose, we were using phenobarbital. Others have used methadone. That's a little more recent. This is a study from Maine, which most people don't get to stay because there's not a lot of people in Maine, but there's a lot of opioids. So this is a study where they compared methadone versus morphine and found a lower length of stay for the group that got methadone. And then as another additional medication, this was studied at Johns Hopkins in Baltimore, was using Clonidine. So they use tincture of opium plus Clonidine. And Clonidine is used in adults. There's Clonidine patches, and it kind of blunts the norepinephrine response. So it can help with withdrawal signs in adults. So it was used in these kids and found a lower median length of stay for the group that got Clonidine. And that we actually, based on that, even though this paper came out in 2009, and I started as a hospitalist in 2006, and there was, we had just started a program, and the guy before me only did it for a year, and he had seen an abstract on this, and it took them, for some reason, 3 years to publish it. And he got us to start doing this. So when I started, we were actually using Clonidine. We eventually stopped because we had lots of side effects from this. So we had a lot of bradycardia and some low blood pressure. So it turned out we looked at about 40% of the cases we were stopping the medication. So we just pretty early on just stopped using it altogether. So what generally has been considered to be the standard approach to the care of these babies, and the picture is an example that I found on the internet, is medications are the key to treatment. And again, in a lot of places, they won't, to even get the diagnosis of NAS, they're really looking at patients who are treated, and treated means getting medication. Second is the most common location by far is NICU. There is variation in this. You will see some of the care done in general newborn nurseries, some on general inpatient units where I would take care of them, and then even some at home. Often patients will be sent home with medications. If they are, that's almost always phenobarbital for prolonged periods. But the mainstay is really NICU. And there are, of course, combinations of the different locations, but NICU is kind of the center point, which is why this is a perinatal committee. It's probably mostly neonatologists, and most of the folks who are doing work on this are neonatologists. The other part, so there's going to be 5 of these. The next standard part is Finnegan Score. So there are Finnegan Score, again, developed in the mid 70s along with the Lipset score, but nobody really grabbed onto that one, even though that was recommended by some of the old AAP guidelines, was to use that score, but it may be something that none of you have heard of because nobody ever uses it. Finnegan Score is a little bit long, and so there have been lots of efforts to make it simpler and to still get the same results, and several of those efforts have been successful, but nobody cares. This is what people use. And there was a 2012 survey that showed that 95% of places in the United States were using a version of the Finnegan Score. And most people are using a modified version. The modified version is minimally modified. The original version had 3 different possible scores for excoriations, and in the modified version, there's just 1 score for it. So it's not majorly changed. So the Finnegan scores are really the standard approach. Medication dosing, once your Finnegan scores are above 8, and again, it's usually 3 scores of 8, you start medication, and you will go down a weaning protocol, which is usually 10% of the original dose, either every day or every other day that your scores remain below 8. So this should sound familiar to many of you. And that is, so there is, I think most places will do it every day that the scores are below, but that's not necessarily standardized, but it's some version of that slow wean. And then the staff cares for the baby. This is really more a feature of the NICU. That and with this population, that there's very rarely families around, and so it's mostly the staff caring for the babies. And then when the baby's ready to go home, it's kind of handing off the care to the parents. And so we kind of handle it in the hospital and hand it off to them. So that's generally the 5 elements of the standard approach. And most of that we were basically doing that at Yale when I started. There are a couple small little variations. So what we were doing is when a baby was born and we knew there was opioid exposure, the baby was taken from the delivery room and brought right to the NICU and put it in an isolette and then monitored using the Finnegan tool. And when they got 3 scores of 8, we were starting morphine and initially Clonidine, but we eventually stopped that. So we're using the Finnegan scores to guide the morphine, and then weaning them initially every other day that they had 3 scores below 8. Or all their scores are below 8. So 10% every other day. The one little feature is at the time, our NICU was much smaller than it needed to be. So we had a lot of demand for the NICU. And so they were looking for babies to transfer. And what they started to do is on average at about 7 days of life, mostly when they felt like they had stabilized the medication dosing, they weren't going to be going up anymore, they would transfer the baby to the general inpatient unit where I, as a hospitalist, would take care of them. And so that was one of the little tweaks. And then the same idea, even on the floors, we had the staff, it was still staff caring for the baby. There were 2 families I remember in the first few years that actually stayed throughout the hospitalization, because once you're on the inpatient unit, you can actually stay. And that was unusual and a little bit harder on the staff at the time. So that is the standard approach, and that's pretty much what we were doing. Now, we're in for a long day here, so we're gonna keep everyone awake with a little bit of a game here. What you have here is 9 dots in front of you, and what I'd like you to do is connect on your screen, connect all 9 dots using 4 lines without taking your finger off of the screen. So 4 straight lines, connect all the dots, and I'm going to give you about 30 seconds or so to do it. Good luck, everyone. Hopefully everybody's feverishly working on this. Okay, I hope everyone got it. So the way you do this is this. So that's the solution to it. So you have to go outside of the box to do this. And for those of you who've heard, I'm sure you've all heard the phrase thinking outside the box. This is actually where it comes from. It's from this game. And it is not what I thought it meant. I've been using it wrong, I realized, for my whole life. I always thought of thinking outside the box as thinking extremely creatively and totally differently than everybody else, so that everybody is working on this answer and they're deciding whether the answer is 5 or 6, and you come in and say, no, it's purple. And so that is not what it is at all. What it actually is, and why this was so difficult for everybody, and certainly for me when I first did it, is if you look at this, it's 9 dots. It's not a box. And so what happens is our minds turn it into a box. And so thinking outside the box is not actually thinking creatively. It's realizing that there isn't a box, that these rules that we're making for ourselves are rules that we've invented, that they're not real. And that is really relevant for medicine, where we create all sorts of boxes just because somebody has done something previously, and we feel like we must do it that way. And so it's really important to start looking at where there are boxes in what we're doing. And this was a great example of that. So it's, again, understanding there isn't a box. This is not what we have to do. So back to our story at Yale. So I, again, took over as a hospitalist in 2006. And one of the things that we do as hospitalists is we're trying to move people in and out of the hospital pretty quickly, because there's usually a pretty big demand, and a lot of people are admitted when they don't really need to be, and we're trying to move them along. And again, our average length of stay is somewhere around 2 days in general. And so when we have these long lengths of stay, we get pretty frustrated. So this was, when I started, this was not a population I spent a lot of time thinking about. Mostly because it wasn't just the population I was terribly interested in. In fact, there were 2 hospitalists, and we had 2 different units. We had an infant toddler unit and a school age unit. And the other hospitalist had been here a year before, and he got to choose, since he had seniority, which unit he wanted to work on. And he wanted to go to the school age unit because 2 reasons. 1, that he didn't want to take care of these babies. And 2, because he said he liked teenagers. Now, one of those is believable and one of those is not. So at any rate, I got stuck on the infant toddler unit. So when those patients were transferred up to the general inpatient unit, I was taking care of them. They already had a protocol that was built by our neonatologists who had been around forever, who had trained me. And so this was not a population I had to think about. This was very easy to manage. You we would sit around the table, we would read off the Finnegan scores, and we would say go up or down or stay the same on the dose, and then that was really it. And you didn't really have, there was nothing on your exam that was going to change anything. The parent usually wasn't there, so you didn't have to talk to anybody. And so that was really it. And so it was easy, but they were there forever, and it could be, and it wasn't terribly interesting. And my predecessor, actually, to keep the resident team interested, would take the Finnegan scores at the end of the week and play the lottery for the residents, just to keep it interesting. They never won, and I didn't do that because I was too cheap. But that was kind of what happened. And so where this really started is that we got kind of frustrated because we were using this weaning model that was every other day. So you had to have perfect scores for 2 days before you could go down on this really small amount on your morphine. And so what we ended up doing is simply fudging that. Basically, we would just because basically, you're looking at a kid and he's doing fine, and the next day he's doing fine, and we've gone down this very tiny amount on the morphine, and why can't we go down another very tiny amount? And so we just started to kind of do that. We didn't change the protocol. We didn't tell the neonatologist. We just started going down by this small amount every day. And so, if you do the math, if you're only going down every other day, the best you can do with a length of stay is about 3.5 weeks if everything goes perfectly. So by knocking that off, we were able to reduce the length of stay by about 6 days. And so you could think, reducing a length of stay by 6 days is a huge change. And so if there were a medication that did that, that would be quite amazing. This is not something we were looking at, but one of my colleagues was moonlighting at one of the community hospitals up the road, and he found out, he looked at our data, and at their hospital, their length of stay was about 6 weeks. And so they wanted to know what amazing things we were doing at Yale to get such a low length of stay, and they asked me to come give a talk. And when people do that, we're supposed to say yes. The only problem I had with this is I was supposed to give an hour talk, and I had about 90 seconds of material. I had our protocol, and I had the little anecdote about the lottery, and that was it. So I had to, this was really disappointing for me. I had to read all those articles I mentioned before and try to develop some sort of presentation. And so when I started to do that, I found something that was really interesting and didn't make sense to me, or I thought was interesting. Maybe it wasn't. But when I looked at those medication studies and I kind of lined them up, because they show them all. If you have a review article, they'll show you all of them, but they're just trying to compare the p-values and what's significant and what's not really looking at it, just stepping back a second and looking to see if this all makes sense. So this is I showed you 5 articles before, and here they are again. So DTO's diluted tincture of opium. So you have this is the Johns Hopkins study, tincture of opium versus tincture of opium plus clonidine. Median length of stay was 17 days versus 12 days. For morphine versus phenobarbital, this was the average length of medication treatment was 8 days versus 12 days. For morphine versus tincture of opium, the average length of stay was 30 days versus 27 days. For this is a study from Brown, tincture of opium versus tincture of opium plus phenobarbital. This is the one that had half the length of stay, as you can see, 79 days versus 38 days. And then methadone versus morphine, the study from Brown was 17 days versus 24 days. We're still publishing articles on this. There was one a couple of years ago in the New England Journal of Medicine, which was comparing buprenorphine, which is an even newer treatment, versus morphine, and found in the morphine group, the length of stay was 33 days, and the buprenorphine group, it was 21 days. So these are continuing. And so what seemed odd to me is if you look across, now remember, these are all newborn babies. Their exposures are all fairly similar. They're all exposed to an opioid. And in most of these studies, somewhere between 30 and 40%, sometimes a little bit more, have polypharmacy. A much higher percentage will be exposed to nicotine as well. And the protocols are really very, very similar. They basically follow that standard of care where it's using Finnegan or some version of the Finnegan and 3 scores of 8, and then giving the medication and doing these weans. And so if you look at this across this, so for studies that use tincture of opium, the length of stay ranged from 17 days to 79 days. And for morphine, it was 8 days to 30 days, or if you include the more recent New England Journal article, it's 33 days. So that is a really, really broad change in what across these systems with kids who are really on the surface look fairly similar. And so you don't see this in any other disease process. You have this wide variability in length of stay. It doesn't make any sense. We see some of this when we take care of kids with bronchiolitis, and you'll see from studies that we consider to be greatly variable, where the average length of stay in one study will be 2 days and another will be 6 days. And that seems crazy to us. This is, you're looking at things that are as high as 79 days. And so why was it? We asked ourselves, well, why do we think this is happening? And of course, our answer was that we didn't know. But they thought maybe it's not about the medications. And so if you look at the AAP guidelines from 2012, they will, and there's a newer version now, which is a little bit better, they will list non-pharmacologic care, which I sort of mentioned earlier as the first line treatment, and they spend about 56 words on non-pharmacologic care, and they spend 1,650 words on medications. So non-pharmacologic care is the first line treatment, but not really. So it's not, if you're a neonatologist and you're saving the lives of these impossibly small babies and doing, and putting kids on ECMO and doing that kind of stuff, the idea of kind of bouncing a kid like this as an actual treatment is a little bit of a hard sell. And so, it's kind of given lip service that, yeah, we do all these things, but the real stuff is the medication. And in fact, if you look at these studies, none of them control for the non-pharmacologic care. Some would say, yeah, we do that. We do that for everybody. But the difference is, you could try to think, but you don't really know how that's going and how much is being delivered and whether the parents are there and all that kind of stuff. And so I try to think of it, if we were doing it the other way and we wanted to study swaddling, and we had one group that was swaddled, one group that wasn't swaddled. And then we said, yeah, we gave medications to some of them. I'm not sure which ones. It doesn't really matter. We just gave it if they needed it. That would not be published, and we would be made fun of for doing something like that. But with non-pharmacologic care, since it's not really real, that seems to be okay. So what we did at that time is said, like, okay, well, let's actually just really do that, and let's maybe there's something to it, and maybe we can. Maybe we'll just actually start the most non-innovative quality improvement project ever, and we'll just really follow the guidelines. So when we looked at where we were starting, from 2003 to 2010, we had 150 babies in our NICU who were exposed to methadone. And most of the data I'm going to show you is methadone exposed babies. And the reason we do that, basically the results are the same if we use our entire population. They'll be slightly better. So here it was 98% of the kids. If we use everybody, it's 94% of the kids were started on morphine. But what we found is that this is the group that we could be very confident was going through withdrawal. Some of the other exposures were smaller, and there wasn't necessarily evidence of withdrawal. So we want to make sure we're looking at kids who definitely had withdrawal. But again, we use this for everybody. The approach, we don't care about the exposure. So in this case, at the start, we had 98% of our kids were reaching 3 scores of 8 and started on morphine. So there were only 2 kids, and we'd gone about 5 years without having any. So I'm going to show you the data going forward in the form of a control chart. And so this is, for those of you who aren't as familiar with a control chart, let me orient you. So on the x-axis is the date, on the y-axis is the length of stay in days. Each yellow dot is an individual patient. And the black line is our average. That's our average length of stay from 2008 through 2010 was 22.5 days. The green line is the Vermont Oxford did a quality improvement project across 199 hospitals and found that they were able to reduce the length of stay by 2 days, from 21 days to 19 days, which is enormous. If you have a 2-day decrease in length of stay across 199 hospitals, that is a tremendous decrease in length of stay overall. So that's a big deal. And so that was looking at that as something to sort of benchmark against. And then the red lines are our control limits. And these are basically 3 standard deviations from the mean. And so the utility of that is to say the next baby you could predict will fall somewhere between those 2 red lines, their length of stay, which right now you can see is not very helpful, because we could predict that the next baby is going to stay somewhere between 0 and 47 days. So not very helpful. So if you're doing a quality improvement project to reduce length of stay, there's two things you'd want to see. You want to see the median line go down, and you want to see the red lines get closer together so it's more predictable. Now, what I will say is we eventually published an article saying that we were trying to reduce length of stay. We weren't really. Our goal was, this looked like it was going really poorly for both babies and moms, and we wanted it to go better. And one of the side effects of that effort was that the length of stay went way down. It actually wasn't really our goal. This wasn't making anybody feel good. So that was really why we started doing it. So what did we do? When we embarked on this, this is the part of the talk where I talk about sailing, which seems appropriate. So I don't know much about sailing, but I can tell you is this is actually an oil tanker. This is a ship called the Thomas W. Lawson, which was built around the turn of the 20th century, so in the early 1900s. And this is where, and again, it's an oil tanker. And so if you were a shipbuilder during this time, this was a tough time, because if you were building sailboats, this is when steamships were really taking over. So if you were a sailboat builder, you had a choice. You could push your sailboat technology as far as you could, or you could entirely change your paradigm and switch over to steamships. And so this is the only 7-masted sailboat ever built, which initially sounds impressive, but then you wonder, why was it the only one ever built? So first of all, it made less room for the oil, which is a problem if you're an oil tanker. And it became very difficult to maneuver, and it lasted about 2 months before it ran aground and sank. And so what you think of with quality improvement, I thought this was a good analogy for quality improvement, is what we often do is we take the current system we have and we try to just maximize it and push it as far as it will go. And there was a study published in 2015 out of Ohio, and nobody does quality improvement better than the children's hospitals in Ohio. And that's where I did my training in it. And that is sort of the mecca of quality improvement. And they took the traditional model that we talked about before, and they just pushed it as far as it would go with great results. And they were able to lop about 10 days off of their length of stay and get it into the high teens as well, or the low 20s in length of stay from above 30 days. So really impressive work, really, by just taking everything and doing all of those elements that we mentioned before. The Finnegan Score is doing it really, really well. And very consistently, and doing their weans, no extra days in their weans. They just pushed it as far as they could go. What we wanted to do was to build a steamship, to do this a little differently, and just to look at, were we doing this? Was the whole way we were doing this, did that make sense? And so what we started to do was something very simple. We just took all of the elements that we were doing and asked why we were doing that. Because the original answer was because that was the protocol I was handed. And I was looking for a little bit of a deeper answer. And really what we found with all 5 of those elements is the reason that we were doing what we were doing today is because that's what we were doing yesterday. And that was it. And the evidence behind it was spotty at best. This wasn't a standard approach. This was a traditional approach. This is something we were doing because that's what we did. And we tried to undo that. So you'll see that this approach that we're going to describe and how we came up with it we didn't do anything. We just stopped doing things mostly. So looked at medications. So why were medications the key to treatment? Why was that the number one thing? And why was, even though non-pharmacologic care is the first line treatment, why did places not even consider you to have NAS or significant withdrawal unless you got medication? And in what other disease process is the diagnosis based on whether you get the second line treatment? You won't find one, so don't bother looking. So we started to question this a little bit, and there's a paper from Vancouver in 2010 where they were managing these babies, and they did this sort of wild thing where they took the baby and they took the mom and they put them together. And it was, one of those ideas that was just crazy enough to work. Not surprisingly, the outcomes, as you would think, that is that the babies and the moms both did better with that. And when I remember talking to my brother after we'd done all this work, and I explained to him, he said, so you basically prove that babies like their moms? And the answer is pretty much yes. That's pretty much what we spent all our time doing. So yeah, babies like their moms, and that turned out that they had some good data behind that in Vancouver. And so we said, well, why don't we run with that? So why don't we actually, as we said, just focus on this non-pharmacologic care, really try to pay good attention to it, do it as a real treatment, and treat it like a real first-line treatment. And so when we did that, we saw our length of stay go down dramatically. We were able to bring this down to about 12 days. So we took off about 9 or 10 days off our length of stay by just really focusing on the length on non-pharmacologic care. And so when we thought about this a little bit more, we said, okay, well, why is this? You know, if this were a medication, if we invented a new medication to do this, everyone would be using it. And we said, just add this medication and you'll knock 10 days off your length of stay. We'd all be very wealthy. But as it turned out, we said, okay, well, what is the medication involved here? And we said, well, what is the secret sauce of this? Because we're just doing, you know, we're on the inpatient units. And so we now have a 13-day length of stay, which is quite a bit lower than what they did in the Vermont Oxford study. So what's going on here? And so what's the secret sauce? Because we could control the environment, but what we found that things that we had a lot of trouble doing is we really had trouble feeding the babies on demand. And so, which is a weird statement. So if any of you have had babies before, the idea of feeding on demand is a little bit not feeding on demand is a little bit weird. So the idea of saying, oh, no, the baby appears hungry, but they're not due to eat yet, which is what we would do with these babies. And that may sound familiar to you. You think about that with your own babies. That's not a real thing. That's not how it works. So babies are supposed to eat when they're hungry, and we're supposed to sort of work on their schedule with it, not just saying, nope, it's every 3 hours, because that's when we do it in our institution. So that was a hard habit to break. But babies going through withdrawal often need to eat really frequently. They're using more energy. It can be very soothing. That's one of the ways they soothe. So not feeding them on demand is a real negative, but it's really hard to do in the hospital, because if you're a nurse and you're supposed to do that and you have 4 other babies or 4 other kids and you're supposed to give that one medication now and do this and that, it's really hard to say, okay, I fed this baby 30 minutes ago and now I want to eat again. It's not practical. So that was one thing that we had a lot of trouble doing unless there was somebody at the bedside. And the other thing that was tough, unless somebody was at the bedside all the time, was to intervene really quickly. So if the baby started to get fussy, that somebody could be there and not intervene in 20 minutes when they had a chance to come in, but could go there and pick up the baby right away and maybe try to feed them or hold them or rock them, and do that within seconds. So that, because often with the withdrawal signs, what you'll see is once they start, they really snowball. And so if you can short circuit that a little bit, it can be really effective. These are all things that you need somebody at the bedside all the time. And who is likely to be at the bedside all the time? It's not going to be any of our staff. It's going to be a family member, most commonly the mom, but not always. And sometimes it's just the dad, and sometimes it's both. But I'll probably be saying mom most of the time. But really, it's really a family member, and often it really takes a village for that kind of stuff. So that's what we found, and we said, okay, let's just think of it in those terms, that mom is the medication. So mom is actual treatment, and just think of it in those terms. So mom is antibiotics for pneumonia. Mom is the albuterol for asthma. Okay, let's have that mindset. So if you have that mindset, you start to look at, why are these babies going to the NICU? And so is that a good idea? Because in our NICU, we have a rooming in style NICU now, but that's only a couple of years old. We had the regular cafeteria style NICU where there's 12 babies and everybody's in there, where there's not really an opportunity for the family to stay. Yeah, the environment is loud and bright and bustling. And so that it may not be the best place, but why are we going to the NICU in the first place? So what is it about these babies that needs NICU care? So we looked at it in our hospital. Most of the reasons to go to the NICU are because it's an intensive care unit. So it's really, do they need lines? Do they need support breathing, support with nutrition that like through IV or things like that? And these babies don't need those things. They don't actually need the intensive care. So why were they always going to the NICU? And the reason, of course, they were going to the NICU today was because that's where they were going yesterday. And so there may have been a reason at some point, but it was a little hard to find that. And the answer that's often given is that, well, they may have seizures. And what's often cited is a 1973 paper that was actually the lead author worked in our health system, and he just retired last year. And when we asked them, and it says that there's a 2 to 9% chance of seizures, which is a pretty broad range. And we asked them about it, and he said, well, we weren't really sure if those were seizures. And the reason that that paper is cited and not others is that has not been what's been shown since then. And again, that's almost 50 years ago now. So it turns out, and we during our time have reported no seizures in the time I've been there, which is now 15 years. And even if seizures were an issue, we don't usually admit kids to ICUs because they might have a seizure. If the baby had gone home and come back, they would just go to our neurology unit. And we also, if babies might have seizures or people might have seizures, we have a population who has epilepsy, and they don't spend their time in ICUs. They go about their business. So even if it were an issue, it's not really a reason to be admitted to an ICU. But we have not had that as a real issue. So the indication for going to an ICU is a little bit hard to find. And so we said, okay, are there any negatives to it? So when we look at, this is the website photo of our old NICU. And you can see everyone looks happy, which was not my experience in the NICU. But you can see it's bright. There's a lot of action going on. And there's no parents around because we're rounding during that time. And I actually snuck in and took a regular photo. And you can see it's not the most safe family-friendly area. You can see there's that one rolly chair with the tape on the arm. That's a place where the parent's supposed to stay, but you don't see any parents in here. It's not a very welcoming place, and it's loud and it's bright and it's bustling. It's actually, if you wanted to think of a place to provide the worst case scenario for non-pharmacologic care, this is a pretty good place to start. So the one thing you could do is swaddle the kids. You're not feeding them on demand. There's nobody holding them on a regular basis, and it's loud, and they're going to be stimulated all the time. So this is a rough place to start with. And so when you go to our inpatient unit, it's it's not the nicest place in the world, but it is single and double rooms. Now with COVID, it's just single rooms. And there's a place for the family to stay. At least one family member can sleep there. There's a refrigerator in some of the rooms. They can move in and they can be there all the time. And so and you can also control the environment really well. You can keep it quiet, you can keep it calm. And it's a good environment for the baby and for you to be able to control the non-pharmacologic intervention. So our second thing we did was we started to just say, okay, if the babies don't need to go to the NICU, let's have them not go to the NICU, which seems easy enough. Particularly, we weren't really challenges with that because we're all of these units are in the same hospital. They're like a few floors apart, so there's no challenges with like in some community hospitals where you only have a NICU. We had a NICU, an inpatient unit. We had babies staying on the floor, and so we said, it's okay. Here's what we're going to do. We're going to have the babies stay with their mom, since we think mom is probably the secret sauce to the medicine. And you can think about it. If you're thinking about the NICU from that mindset, you're saying, okay, this is a unit where the moms can't stay, and we think the moms are the medication. So if the mom is like albuterol for asthma, if you send the kid to the NICU, you can't give albuterol. You just have to give a lot of steroids. And if you have them come to the inpatient unit, you can give them both steroids and albuterol. Now, in what situation would you have the baby come in and go to the unit that doesn't carry albuterol? And of course, that's a ridiculous thing to say, but if we're actually talking about non-pharmacologic care as the first line treatment, best delivered by the parent, then that's exactly what we're doing when we're sending kids to the NICU. We're saying, nope, we must care for them here, even though we can't give them first line treatment. For what benefit, and that benefit is unclear. So we said, okay, what we're going to do is keep the mom and baby together. So while the mom is in the nursery or is in the postpartum unit, and at some point during this, we became a baby friendly hospital. So we don't have a nursery, we just have the postpartum unit where the mom and the babies are, that the mom and baby, the baby will go with the mom, and we'll have the nursery do Finnegan scores. And if the scores get above 8, they can send the baby down to the general inpatient unit where I'll take care of them. And then when the mom's discharged, she'll follow. And so that seemed easy enough. And if they have another medical problem, they can, of course, go to the NICU. So that seemed simple enough. It took 18 months of negotiating to get the nursery to agree to do that. Because who wants to take care of this population if you don't have to? And that was kind of that was kind of their thought. Like we don't. This doesn't sound like a good idea to us. We will take a pass. So eventually they agreed to do it. There was a little bit of a protest vote in the beginning. The first 6 patients that were born with this model, the baby was transferred to the NICU for other medical problems that miraculously resolved as soon as the baby arrived in the NICU. So it took a little while, and it was not smooth, but eventually we got it to work. Now we would get babies sent down from the nursery with Finnegan scores of 22 that we would rescore at like a 5. So there was still a lot of anxiety, but I will get back to that a little bit later. Eventually that settled in and got to work. In fact, actually, I'll say it now. What happened there was a period that went by where we realized we weren't getting any babies transferred down to our unit before the moms were discharged. They were both coming down together, and we went up to find out what was going on. And the nurses up there said, yeah, we saw that you guys weren't necessarily starting medication when we sent them down, and we saw how powerful it was to have the mom and baby together. So we weren't going to mess that up. So that just became the standard. They were keeping them together until the mom was discharged. So here's what we saw. We saw with that our length of stay actually, when we started to do this, went down from 13 days to 10 days. But one thing you can see is there's a bunch of kids who had a really long lengths of stay, around 30 days, and even a couple above 40 days. And so what happened there? And actually the red lines got further apart. So it turned out during that year, that was a time where our NICU volume was quite low. So if the NICU ever got a baby with NAS, they kept them throughout the entire hospitalization. And we were kind of doing our own thing and trying these things out on the inpatient unit, and the NICU didn't really know what we were doing. And so you can see that difference in that period during 2013, and that's what happened there. But even with that, the average length of stay dropped. So we're on a roll of questioning why we're doing things. So why are we using the Finnegan score? The Finnegan score, of course, is one of those boxes that you must do. And so, and why was that? And so we started to look at it a little more closely. And there were some things that were a little frustrating about it. So one of the things was that you could have a kid who had 2 scores of 8 and they have 1 score of 7. And they've sneezed 3 times. And then they sneeze a 4th time in some indeterminate period of time. And then they get another point. So now they have 3 scores of 8, and now we have to give them a dose of morphine. Except we don't give them a dose of morphine. We give them 100 doses of morphine because we have to stabilize their dose, and then we have to go down. Even doing the everyday weaning protocol, you're up to a minimum of 80 to 100 doses if everything goes perfectly. And so that one extra sneeze caused them to be in the hospital for 2 more weeks and to get all of these doses of morphine. And so that seems strange. So if you have this model, what's really weird is you have some kids who stay 5 days and they don't ever get 3 scores of 8 and they go home at about 5 days. And then you have the other population all stays 3 weeks or longer. And there's really nothing in between, right? Because it's very hard. If you're going to go through this weaning protocol, you got a minimum of 10, 12, 14 days. And so you can't just stay for like 3 extra days. So that was a little bit of a problem. It's very fraught to actually get your 3 scores of 8. So that extra sneeze, started to think, where else are we giving 100 doses of morphine for an extra sneeze? That seems a little bit extreme. So we started to look at, okay, before I go on, I wanted to say, so why, you can think if you're using this model in your institution, is who decided to use 3 scores of 8? And I'm going to assume you do that, or 2 scores of 8, or whatever it is. How did you guys come to that decision? Most of the time, what I found is that nobody has any idea. That's just how it's always been. And so it took me a while to dig it up, but this is why it's 8. You ready? Here it is. The infant, this is from the 1975 paper by Finnegan. The infant with a score of 7 or less was not treated with drugs for the abstinence syndrome because, in our experience, he would recover rapidly with swallowing and demand feedings. Infants whose score was 8 or above were treated pharmacologically. So that's it. That's just the number they picked in 1975. There are no follow-up studies looking at the right number to use. It's just used from this paragraph, and that's it. Just That's just what they picked. So that's why you're using it, just so you know. So what are some of the problems with Finnegan? First of all, if you use this model of treatment, you have the longest lengths of stay of anything in pediatrics, and you use lots and lots of medications of questionable safety. 2, the whole purpose of the treatment is to get the scores below threshold. So I don't even have to see the baby. I don't have to ask how the baby's doing. My question is, what are the scores? And are the scores below 8? Because then I can go down on the medication by this tiny amount. So that's it. You don't have to say hello to the baby. You don't have to do anything. It's just, you don't have to ask how they're doing. How are the scores? And so you don't actually care if they've sneezed fewer times. You just care if you've seen it fewer times also, right? So if they may have sneezed 10 times, but you only saw 2 of them, then they don't get a point. So this is a tricky one. So if you look at that, at the Finnegan tool, I'm going to pop back to the Finnegan tool real quickly. There's a bunch of items on here, and in the beginning I showed a picture of a baby when not the baby from the website who was going through withdrawal, but just another baby who's actually my 11-year-old son, who may wander into the room at some point, and he was a really miserable baby, and we had a lot of trouble consoling him and getting him settled down, and we were pacing all the time with him. And as I'm taking care of him at home, and then these babies at work, it made me think, what if I went to the pediatrician and said, like, we are having trouble with him. Okay, what dose of phenobarbital are you going to give us? They would have made fun of us for that as well. So that's not really something that happens. But he had some of these symptoms. Now there's 3 of them that he did not have, and these are the 3 that have been found to be the most specific for withdrawal. So he had so the 3 that he did not have, among others, but the 3 that he definitely didn't have are: 1, increased muscle tone. And there is yet to be a baby I've seen exposed to methadone who does not have increased muscle tone. And the easiest way to tell that is if you pick up a baby by their arms and they come up like a board. A baby that age, their heads are enormous. You've seen them put their hands up, they go up to here. So their heads are enormous, and they're supposed to lag. And if they don't lag, that's definitely a hypertonic baby. And I'm yet to see, as I mentioned, one who's methadone exposed who does not have increased muscle tone. So that is, you do not really see that outside of withdrawal. The tremors when disturbed is another one that's pretty specific to this. You can see tremors in other areas, but it shouldn't really be hypoglycemia and other things like that. But severe tremors when disturbed, that's pretty specific to withdrawal. And then the hyperactive Moro reflex. So those are things that are really specific to withdrawal. Now, here's the thing. How do you know if a baby has tremors when disturbed without disturbing them? So I don't know. That's not a trick question. I don't know how you do it. So in order to do the Finnegan tool appropriately, you have to take the calm, snuggled baby, unwrap them, check out their Moro reflex, poke them to see if you can get them to withdraw. And then so you're basically exacerbating the signs of withdrawal just so you can measure to see if you can make the baby show signs of withdrawal. Now, I'm not sure what the utility of that is. And in fact, it seems to me that that's actively doing harm. And any of the nurses on the call already know that and have known that forever, have been trying to devise ways to get around doing those things, because that doesn't make any sense. And then my book is harmful to the baby. It can also be, these scores can be slow to respond. We would do these scores every 4 hours. So you could have a baby who had got a score at, say, 10 o'clock in the morning, and they were fine. And then at 12 o'clock, they are totally inconsolable, and they got a score of 10. And so what do we do with that? Nothing. And then they're screaming all afternoon, inconsolable. No one's ever, the physicians don't know anything about this because we're just looking at the scores. Next score is at 4 o'clock. This baby is still inconsolable. Another score of 10. And we go all the way to 8 p.m. And that's when we finally get our third score of 10. And now this is now 10 hours later. And now we can finally intervene. So that's a little bit slow to respond. And of course, as I mentioned before, this is powerful and potentially harmful meds to give to treat a sneeze or a yawn. We don't probably care much about sneezing or yawning. And now when we thought about this, said, okay, at this point, I've seen over 500 babies exposed to methadone, and every one of them's had withdrawal. So if I concede that the baby's going through withdrawal, and I know they're going to, what exactly is the point of counting sneezes and yawns? We don't care about that. We know the baby's going through withdrawal, but I'm not I don't know that I'm accomplishing anything by limiting the number of yawns or sneezes. So we said, okay, if we don't really care about all these elements and we know the baby's withdrawing, then what are we trying to do? And we said, well, we want the baby to be able to function like a baby, to do things that babies are supposed to be able to do. And if they're able to do things that babies are supposed to be able to do, then we are managing their withdrawal well. And so that was our goal. And so the job description of a baby is pretty limited. So we said this was a big deal. This is the idea of realizing, you know what, the Finnegan score there, we looked at the Connecticut legal code. There's nothing about the Finnegan score in there. And so this is just the idea that we had to do that was a box that we created. It was a big deal to get rid of it. And then, of course, as soon as we did, nobody cared anymore. But once we stopped using a Finnegan score and we said, we're going to use this functional approach to evaluating babies and intervening on them. So we simply said, okay, what's the job description of a baby? They're supposed to be able to eat. They're supposed to be able to sleep, and you should be able to calm them down at this point. This is before you should have any colic. And so this baby should be consolable. And that's basically it. They're supposed to poop and pee, but that's not really an issue in this population. So we are part of a health system that is now moving a little bit better than it did then. We were newly a health system, and in order to change any protocols, you had to get all the hospitals to agree, and we had no mechanism for that. So you're sort of stuck with your protocols. And we had the Finnegan tool on our protocol. So everybody had to be evaluated with the Finnegan tool. So we took advantage of that in this case. We took 50 babies who were admitted over about a 18-month period and onto our general inpatient unit. And we assessed them basically every 4 hours using the Finnegan neonatal abstinence scoring system, which is what the Finnegan's called, which, by the way, is not what Loretta Finnegan called it, but that's what we all call it now. But we did not use these scores to guide management. So we just looked at these and we said, okay, if these are the scores, they're somewhere. I never knew what they were. They were buried somewhere in the chart, but we could dig them up later. We didn't use them to guide management. We used this eat, sleep, console idea. So if you weren't able to eat well, sleep well, or be consoled, then we would give you medication. That's what we did at that time. So what did we look at? We looked at the proportion of infants that got morphine versus the portion that would have gotten morphine if we used the Finnegan approach. In other words, if they had 3 scores of 8, they would have gotten morphine. So we looked at who we actually gave morphine to and who we would have if we used Finnegan, who Finnegan would have told us to. And we looked at how often the approaches disagreed and then what happened the day after. So if they disagreed, so in other words, if Finnegan said give morphine and we didn't, how'd the kid do the next day? And here's what we found. There were 50 kids, and if we used Finnegan tool, we would have given 31 of them, or 62% of those kids, they would have gotten morphine. We only gave 6 kids morphine. So there were 25 kids who didn't get morphine because we switched this approach. And there were 78 days where we gave less morphine than Finnegan predicted. And on those following day, the average Finnegan score was down by about a point and had decreased in almost 70% of the cases. There were 2 instances where it went the other way, where we had an inconsolable kid who we were giving morphine to, and their scores had not reached 3 scores of 8 yet. So in both cases, despite us giving medication, the average Finnegan score was up by almost 2 points the next day. There were no readmissions in this study. There were no seizures, no ICU transfers. These babies all did well, even though they were going home much sooner. So this is this website picture of a baby going through NAS. If any of you have ever seen a news story on NAS, it usually includes the doctor standing next to the isolette of the screaming baby. And what we started to think about is, okay, so what would we do for this baby? We would give morphine. You might give methadone. This person, they might give buprenorphine. We can argue about that. And then we said, okay, well, what would you do if we said, oh, I'm sorry, we made a mistake. This baby is not a baby with NAS. They're not going through withdrawal. What would you do then? This is not a trick question. You would probably pick the baby up. I know. So this is our first tenet was mom is the medicine. And our second one is pretend it's a baby, or treat the baby like a baby. Do what you would do if it were a baby. And you'll find that works really well. So instead of having the baby in a box screaming like this, this would never be a picture you'd see in our hospital because somebody would be holding the baby. So on to medication dosing. So of course, we all go through these weans. Most of you probably have a weaning protocol that I imagine is somewhat what we talked about, 10% every day or so. What is it about the earth going around spinning once that's when you wean the medication? Because it has nothing to do with the pharmacokinetics of morphine or methadone or any of these medications. So why do we do it that way? And of course, the reason we do it that way today is because that's what we were doing yesterday. There is absolutely no evidence for this in the neonatal population. There is a little bit in the adult population, but I'm not sure that's very meaningful. So what we were seeing is this situation. You'll notice this took a long time because it seems like we really know what we're talking about now, but we were trying to think of this stuff, and it still took us a long time to come up with most of this. So we would have these babies who might have gone to the NICU for some other reason, and they were there, and they would start them on morphine, and then they would transfer them up to us. And then we would have this baby who was started on morphine. We'd say, oh, well, I guess we need to go through the wean because we probably wouldn't have started morphine, but here we go. And so we said, well, wait a minute, why are we doing that? When these babies are coming up from the NICU, we're greatly increasing their first line treatment. We're doing all this non-pharmacologic stuff, usually with the family there. And even if they're not, we're still delivering it. And so if we're doing that, can't we decrease the second line treatment more quickly? So instead of doing it every day, we would do it up to 3 times a day if the kid was doing okay. And so instead of getting off the medication in 10 days to 2 weeks at the earliest, you could do this in about 3 days. So that was really nice. But then we even thought, well, why the heck are we doing that? So we started using the medication as needed. And so there's a couple of reasons we thought of this. One is this is really simple observations. You'd have these babies who the mom had been there for 4 nights in a row, and the baby had done beautifully. When we were doing the Finnegan scores were all low. And then one night the mom can't stay. And so overnight, there's nobody there with the baby, and the scores are all above 8. And we get to the morning, and the mom's back, and the baby's doing fine again, but we have 3 scores of 8. And so we started to say, okay, does this baby need more medicine or more mom? And so we started to obviously lean on the side of mom. The other thing that would happen is you've probably seen this in some of these babies, they have these times of day where they're a little worse than other times of day. And so I'll give you an example. It's going to be 2 examples. So first, it's 3 o'clock in the afternoon, and we have a baby who is inconsolable. This baby is screaming. And it's been doing this for 10 or 15 minutes. The nurse comes, we all go in together. We try different things. We try to feed the baby. We notice the mom's not there. It turns out she went out for a cigarette. We call her and get her back there. And then the baby calms down and is doing fine. Great. Another scenario, it's 3 o'clock in the afternoon. Same thing happens. We go in and we're trying to calm the baby down. The mom's not going to be back for a few hours. We try to feed the baby. We try to do all the things we do. And we can't console the baby. So we give a dose of morphine, not 10 hours later, but right then. And now, so they get a dose at 3 o'clock. Next dose is due at 6 o'clock. We do it every 3 hours. Now mom is back. Baby's quiet and calm in her arm. Has been feeding well. Has been doing great. Now, what exactly would that next dose of morphine be for? So we couldn't figure out what it would be for, so we stopped giving it. So often what we found is if we did it that way, we gave that dose at 3 o'clock, and then we didn't give any more doses because then we just got the baby over that hump. At most, we were giving 2 doses, and that has been repeated in several other institutions. And so we started using this as needed dosing, which should really make it much easier to give a dose of morphine. It actually usually doesn't impact the length of stay at all, because what we have found is that the peak withdrawal tends to be at day 3 or 4. And if we're giving a dose of morphine or 2 doses of morphine during that day and not giving anything else, that baby, if everything's going well, could still go home on day 5 or day 6. And so it should be much easier to give it. You're not buying that kid 100 doses. If you give a kid a dose of morphine, you give them a dose of morphine. It becomes much easier and much less fraught. One of the things that we had seen that was really interesting about this, I was at an NAS conference up in Dartmouth, and Dartmouth has always taken great pride in the great non-pharmacologic care they do. And they had a panel of moms who had a good experience, and they had an hour to talk, and they spent the entire hour talking about Finnegan and how they said, okay, I know she's already sneezed twice, and I know that the nurse coming on tonight is a really a hard scorer. And did anyone see that sneeze? And because they knew if this baby got those 3 scores of 8, they were going to be stuck there for 2 more weeks doing this. So they were totally traumatized by the scoring tool, and they had them writing down all the signs of withdrawal just to remind them what was going on. So that was really eye-opening to me of how much stress that was putting on the families. So when we did that, we saw our length of stay is now coming down to under 8 days. And you can see if you look all the way to the right, that there isn't a kid who stays, our longest length stays about 12 days, and that our 3 standard deviations from the mean is now below the Vermont Oxford score. So this is, we now have a steamship. So this is not a sailboat anymore. This is a new model of how to do this. We weren't done. The last thing was the staff caring for the baby part of it. So when we first started doing this, what would happen is we would take the baby at the end of the hospitalization and kind of, we would call the family. And again, initially we had these 4-week lengths of stay. We would call them as we were ready to go the next day and say, look, yep, we're done. The baby can go home tomorrow. And the family would say, we don't even have a crib. What are you talking about? They had kind of gotten to spend the last 3 or 4 weeks pretending that they didn't have a baby yet. And of course, this is a really vulnerable population. And we had the mom and the baby, and the family and the baby had not bonded at all. And this is going to be a family's in a vulnerable situation. And this baby who is still going to be a little bit difficult to deal with. And they're just kind of meeting each other now at 3 or 4 weeks down the road. And so, we thought that probably wasn't great. And really, again, our goal was to have this go well for the mom and baby, both in the hospital and at home. And that did not seem like a situation where we're setting them up for success, where we just do everything with the baby and then we hand over. And so we didn't want to do that anymore. And so we were really affected also by this paper by Lisa Cleveland out of San Antonio, which was a qualitative paper on moms in the NICU there who were being managed with neonatal abstinence syndrome. And there were 4 major themes of how the moms felt. If you haven't checked out this paper, it's really, I think, important one to read. So one, the moms felt addiction was misunderstood. This is now, I think we're doing a little bit better with this at this time. I think people are understanding addiction as more of a disease, less of a choice. But that is not, we're still moving in that direction, but that definitely wasn't what it was when this was published, probably about 10 years ago now, or maybe a little bit less. Moms felt guilty. They knew that whatever they were taking, even if it was prescribed, was making their baby go through this. They didn't need us to remind them of that. They felt judged by the nursing staff as well. And if you look at some of the qualitative studies on the nursing experience, the nurses say the same thing, that we're judging these families and we're kind of angry at them. And I think, if you think about the population in the nursery, it's these kids who are sick or have had these birth defects, and really nobody's to blame for anything in there, except for this population. You can point to say, if the mom wasn't doing this, then this baby would be okay. And that is often really difficult for a staff that is so dedicated to the care of these babies to know that this was something that was unnecessary. And so that is often really hard for some of the staff to deal with, understandably. And so, and of course, the parents would be mistrusting of the nurses because of this. And they said, well, if they think we're, they feel this way about us, that we don't really trust them to take care of the kids. And there were some of these quotes that, there are a lot of really powerful quotes. And I'm going to tell you about 3 of them that I found really powerful. This is from one of the moms. His nurse was like, his muscles are locking up because of his junkie mom. I didn't want to visit. I would call before, and if that nurse was there, I wouldn't even go. So again, for those of you who had children, imagine the idea of, first of all, visiting your baby, and second, not feeling welcome to visit your baby and not going. That is not good. Because we're going to leave, he's going to cry, and they're going to leave him crying because they're going to be like, you know what? His parents are jerks. And this is the last one. This is longer, but this was really powerful for us. If you're using while you're pregnant, you have a problem, a big problem, and you need help. You obviously don't care about yourself, about anything except the drug. Make it a little bit easier on that mother if she's showing initiative. If she's taking the time to be there, if she loves her child, you can see it and you can feel it. If it's obvious that she's there for the baby, then embrace it. Make it easier. You don't know what her circumstances are. You don't know what she's been through or how hard her life has been. You don't know what she was feeling when she was pregnant, if she was being abused, if she was poor, whatever the reason she was using while she was pregnant, you just don't know. So try to make it easier for her. So we realized as we were reading this that, first of all, we didn't want anybody in our hospital to say any of these things. And I'm sure that most people don't want to see that in their hospital. And this one was pretty powerful. We said, are we making it easier? No, we're actually making it harder on these moms. And we talked to the nursing staff in the beginning of this, one of our nurse leaders, and says, yeah, we always found it harder if the parents stayed. So, with most families, we're making up the cot and we're fluffing the pill. And this This group, if there's a cot, we're kind of throwing the sheets on the bed. We're trying to say like, listen, it's easier if we just do this and you come back later. And so it's not how we would want to be treated. And if you think about how this is helping anything, it's really not. And that anger that people will naturally feel, it's not productive. And if you're really thinking about how this is going to go well for the baby and the mom, having the moms feel this way is certainly not helpful. So we wanted to make it easier. And so we said, we got to start this prenatally, and we have to empower these moms to know that, yes, maybe what you were taking is having your baby go through this, but you are the treatment for it. And we've had one of our nurse managers really loves this mom who just stood out in the hall with her hands on her hips and said, I have everything my baby needs. And it's not something we used to hear. So we started this empowering messaging. We started it prenatally, and we're just starting our hospitalist prenatal clinic to meet with the moms beforehand to go over what the expectations are. And really our role, there's much less medicine to do. And our role really is now as coaches and as cheerleaders. And we want this to go well for the family. We want to build the confidence of the moms and the dads and whoever's going to be caring for this kid, that they have what it takes to care for this kid. And so the question always comes up as well. There's two. Well, first of all, none of the moms, our population is different, which of course, every population is different. Our moms don't stay. And so I will point out that I mentioned earlier, in the first 4 years that I took care of these kids, there were 2 moms who stayed, and that was it. And I remember them because it was so weird. And so it just wasn't in our culture. It's not how we did it. And the moms didn't want to stay, and they could have stayed, but they didn't. And so one is, if you really try, you will see that change, first of all. And so if you're also asking them to stay for 4 weeks versus maybe 5 to 7 days, that's very different. That's only a little bit longer than if there was a C-section. And if you're encouraging them and telling them that they are the ones who are going to cure their baby, and not that it would be great if they were there. Just think about it again. If we think about that medication model, that this is the medication for the baby, that the mom is the medication. What we did first is we allowed the moms to room in, and then we encouraged them. And then we said, wait a minute, if the mom's the medication, we don't encourage the pharmacist to send up the albuterol for the kid with asthma. If you can get around to it, I know that you guys are really busy, but if you could send the medication up, that would be great. But if you can't, we understand. So this is the treatment for the baby. And so we talk about it in those ways. So we're doing it in a positive way, but we're saying, like, this is the treatment for the baby. What can we do to help? How can we make sure that you or somebody can be there all the time while the baby's there? Because that's what the baby needs. And we know we have all these challenges. So what can we do to help? And of course, there's times where it doesn't happen, where the family just can't do it, or they don't want to do it, and somebody else is going to care for the baby. The baby's going to go up for adoption, or it's going to go to somebody else. That doesn't change what the baby needs. So the whole thesis of this is that, if you heard it, and this sounds hokey, but the treatment for the babies is mostly just love. So if the family can't do it, then we as a healthcare system need to figure out how to show love to a baby for a few days in the hospital. And the sooner we can get them to somebody who's going to love them full time, the better. So just because there's no family there and the baby needs to be loved does not, in our minds, mean that baby should now stay for 4 weeks in the hospital on morphine. We need to be able to deliver that ourselves until we can find somebody to do it full time. And so that's where we use our cuddlers. And so that's obviously been difficult for everybody with COVID, but Boston Medical Center, who I'll talk about in a little bit, they have 24/7 cuddlers for this. And the opioid epidemic has touched every community, and there's very little that most people can do about it. This is something that people can do. So if you offer the community an option to actually have an impact on the opioid epidemic, you will find that people will jump at it. People want to do this. So this is the thing. And if you say, well, we can't do that because whatever, that's probably a box, and you probably can do that. So it's just finding somebody to love the baby full time. So just to summarize this, the old protocol was, the whole goal was to suppress withdrawal signs. And the new protocol was to have the infant function as a normal neonate. So again, one is using Finnegan, and one is how is the baby doing? NICU model, mom visits. Our approach, and we do this in different types of hospitals within our health system. We have our academic center, and we have several community hospitals. the whole tenet is the mother and child are together. Mom is the medicine. Remember, number one, mom is medicine. And number two, pretend it's a baby. And number three, pretend it's a mom. Treat the mom with the same respect you would any other mom. That's it. So you can do those three things. You got to figure out the details elsewhere. Finnegan scores, we're treating the number. Eat, sleep, console, you have to treat the infant. You have to actually see how the infant's doing. That's probably a good thing. Supportive care is what everybody says they do. That for us is in capital letters and is the treatment for these babies. Feeding on demand, we don't have that in our protocol. That's a really hard one to overcome. We said that, but it ended up always being feeding on demand as long as it was every 3 hours. So now we have no feeding schedule and we're constantly, this is like a daily thing. If the baby's hungry, feed them. If the baby's hungry, feed them. Morphine was the key to our old protocol. Now that shows somewhere on page 3 of our approach. We still use meds, but obviously much less because we don't need them. Not that their medication definitely has a role in this, but just not nearly as much as we've used in the past. Often it was a surprise. Nobody really wanted to talk about this. It wasn't a pleasant conversation. Now we have prenatal preparation. Everyone knows what's happening coming in, what everyone's role is. And then the staff takes care of the infant. And so that was our initial model. Now our role is to coach and support the families so that they can do it on their own. So in the old model, we were handing the baby over at 28 days to a family that wasn't ready. And now at 5 days, you see the mom standing at the doorway saying, hey, can we go home? I got this. And the answer is yes, you can. So, and here's where we ended up. And this has been our length stay. I haven't updated this in the last couple of years, but our length stay is on average 5.9 days since 2015. And that's about the same length stay we've seen at our satellite hospitals as well, in our community hospitals. So this can be done in really any type of setting. And really, again, we started at about 28 days, and really in the first 2 years, we were over 30 days for our length of stay. And so the percent of patients that we treated initially was 98%. And now we treat 100% of these babies aggressively from birth with first-line non-pharmacologic treatment. We just don't use morphine very much. So we're down to about somewhere between 10 and 20%. I think I think for us, we're used to not using morphine, and there's enough people who don't really think of that as a treatment option that we probably underuse it a little bit. I think we should be giving 1 or 2 doses, probably to somewhere between 20 and 25% of the babies, and we're probably down more like 10 to 15%. And it's usually a dose, again, around day 3 or 4 to help them get over the hump. But what we're finding is a lot of times the families are like, no, I think I got this. So that's that. The average maximum dose, there's been 2 doses in the last 7 years that have gone above our starting dose. And we just went up a little bit on that. We don't have people ask like, well, how do you go up and down? And like, we don't really do it. So I don't really know. And we don't wean. And so as soon as we're off, there've been a couple cases where we've had somebody transferred in from somewhere far away where the baby's been on 6 weeks of morphine, and then we will wean. We'll just do it pretty rapidly. Our breastfeeding rates initially went up. We were basically at 0 and we got them above 50%. Those have gone down since somewhere in our hospital, we made some pretty stringent rules around marijuana, which we're starting to loosen up. So we're hoping that's going to go back up to around this area. And our average cost of care, the suits really like this one, it went down by about 75%. And these are the vast majority are Medicaid patients, and our Medicaid reimbursement in Connecticut is among the worst in the country. So we lose lots of money in all these babies. So they like that part. Obviously, it was not why we were doing it, but those people seem to like it. Boston Medical Center, they've been using a Finnegan approach. They tried to like adjust the Finnegan, and then they developed the Eat, Sleep, Console approach as a scoring tool. Now, I never mentioned a scoring tool. We don't use Eat, Sleep, Console as a scoring tool. It's a way to evaluate the babies. Secretly, I'll tell you, it's actually how we evaluate all babies. You think about in a newborn nursery, if a baby's not eating well or sleeping well or consolable, we usually look into it, which is essentially all we're doing with this population. So the idea of using it as a scoring tool seems slightly ridiculous to me and unnecessary, and maybe a little bit harmful because you end up just looking at the scheduled times as opposed to and so you can be slower to respond. I think if you use it, it's fine, but I think it's unnecessary. We have a place in our Epic. We use Epic, and we have a place where you can document whether the baby's can eat, sleep, or console, and you can put it in and like yep, and that's it. And so if it's a no, then we go look into it. Doesn't mean we give medication necessarily, but we will evaluate. So what we often find is if the baby's inconsolable, that's the case where we're almost always giving medication. We found that sleeping is rarely, usually the baby's having trouble sleeping. They're also difficult to console. And then with feeding is where we will sometimes do things a little bit differently. We will look at if the baby's just totally can't get it together to even suck, that's a case where we will try some morphine, and that will often help. But most of the time, the babies that we see who have difficulty eating are kind of just sort of falling asleep, and they can't quite get there. They latch on, but they kind of are a little discoordinated with it and just kind of like lose interest. We have found no help with morphine in that population. That's one that we will usually a little bit of time will help, and we'll often we'll put an NG tube in for a few days, give them a lot of calories, and then let them work on it. And those kids will stay usually a little bit longer in the hospital. And so back to Boston Medical Center. So they started to use this, and they saw their morphine go down from 82% to 40%. Their length of stay decreased from 18 days to 10 days. They had no readmissions. There are a bunch of other hospitals that have done this. There's a few more even after this, but this is from New Mexico and North Carolina, Oregon, the Boston one's in there, and St. Louis, and also a few places have done separately. Boston looked at their as needed medication, which was really interesting and successful, but that's the model that's been used in a few of these studies. So that's been helpful. It's been, there's no studies looking at how many places are using it. So I just kind of by emails that I get have been updating. There's a few more in there that I've heard from that are using it. And so I probably need to update this, but our group has been talking, I think we've probably hit about 40 states who have been interested in this model. It's really, if you notice, there's really nothing that we added to this. This is mostly an undoing project. And so it's really taking where medicine has done too much, getting it out of the way and getting back to natural processes. So we really think of it as an undoing project. Long-term outcomes, I know we're actually basically at time, so I'm going to zip through this. This is really basically with long-term outcomes, we're not really sure. There's a lot of money going into long-term studies. There's NIH money going into actually looking at the eat, sleep, console model. We don't know any differences. We don't know the long-term outcomes really at all, and certainly not comparing a Finnegan approach versus an eat, sleep, console approach. I'm going to run through this in 2 minutes, but there's studies have shown over time, and there's problems with all these studies, but vision problems, motor problems, cognitive issues, behavioral problems, school performance issues, and even mortality issues. Here's some problems with the studies that have happened so far. Most studies were done before this current epidemic, so they're much older, although many more are coming out in the last couple of years and will continue to come out. There's a small number of studies. There's usually few participants. They have been you'll see in some of these studies, if they're longer term, they'll start with 100 participants and they'll end up with 20 at the end. So it's a little hard to know what to make of that. They're really difficult to control the study. So most of them are done with standard controls, which is probably not the right choice. There's often other substance exposures. There's other risk factors, mental health, poor maternal nutrition, and then the socioeconomic status stuff is the really big one. There's poor prenatal care, and whatever's happening going forward is really difficult to control for. So I think they're all almost have to be taken with a grain of salt. So we don't need to go over all of these, but the one that I wanted to hit on is the best longitudinal study comes from the Mother study from a few years ago. And they followed infants and mothers for 3 years, and they had really good follow-up. They were basically comparing exposure to methadone and buprenorphine, and they had really good follow-up, including and they were in contact with them, and they had a lot of support going through, and they found through 3 years normal development. And they did find that the mother struggled with parenting skills, and so that was the main thing. But this was the best study, and this showed normal development through 3 years. Parenting skills and this stuff I think is really important, that mothers going through this have difficulty safely performing significant developmental tasks with their infants. A majority of pregnant or parenting women entering drug treatment endorse a history of physical and emotional abuse. There's a lot behind the substance use, and substance use triples the risk of child maltreatment. So I think most of our efforts should be on how we are supporting the parents and the family. And using something like the Eat, Sleep, Console approach is a start, but it's really the first week of life that we're doing that. And that needs to continue. And a lot of focus, once we get the in-hospital part going, where we are supporting families, needs to continue as an outpatient. And so what we are doing at Yale is we're obviously, what things to do are to try to limit prenatal exposure. Things we focus on are really, as an outpatient, are parenting skills. We have a great organization that is in our state and a few other states. I don't think it's in Oklahoma, called Child First, but there's other parenting groups and organizations that can really provide support for that. And all of that stuff is evidence-based in other populations. And what we've seen from our group in Child First has shown really, really good results. So I think there should be great focus and money put into that. Substance abuse support, keeping the parents, the parenthood, for those of you who've had kids, you may remember that parenthood is kind of challenging. And so if you're already in a difficult and vulnerable state, making sure that you're getting really good support for your own care, and making sure the emotional bonds with the mother and baby and the family and baby is happening early on in those really important times. And there's lots of data on how important that is. And what we say is, when we're doing this in the hospital, even if our Child Protective Services is going to place the baby with another caregiver, that's often not permanent. And that family has gotten an opportunity to bond with baby. And so when they are reunited, they have that to build off of. And we think that's really important. And we do work, and then making sure that things are going okay. So we have our Yale clinic that does NICU follow-up, follows all of these babies to make sure that if there are any developmental problems, that we're able to intervene early. And so basically, and the other big part is treating mom as a mom. How do we support these families so that we can have good outcomes for both the mom and the baby? And so the conclusions, I think I actually managed to run over time. Sorry about that. It's hugs before drugs. How do we empower families? Rooming in, making sure that mom and baby are together. Non-pharmacologic care as a first-line treatment. Using this Eat, Sleep, Console approach, you don't need the scoring tool. If you didn't have a scoring tool, you wouldn't invent an Eat, Sleep, Console as a scoring tool. Using meds as needed. And then 3 keys to treatment. Mom is medicine, like antibiotics. Pretend it's a baby and treat the mom like a mom. You can do those 3 things at any site you are. And when you say, oh, no, we can't do that, make sure it's not because there's a box there. Oh, no, we can't have the moms and babies in that unit. Oh, really? Why not? And so what we have found is really creative solutions at institutions that have said, we need to be able to have the moms and babies together. Let's figure it out. And then if you're going to not use this approach, whatever approach you're going to use, make sure you decide to use it. So you say, no. We think the Finnegan approach is better. Here's why. Here's why we're going to use 3 scores of 8. Here's that. So make sure you can answer those questions. We say, why are you doing what you're doing? And I think that is it. This is obviously, I'm the front man for this, but this is a major team approach. And so we have a whole group of people who have really worked really hard on this. So thank you, everybody, for your time.
Thank you so much, Dr. Grossman, for that always excellent presentation. I learned something. I've heard you a few times, and I learned something new every time. So I appreciate that. I do have one question here wanted to get to, and then if you have other questions, we will be having another question and answer session at the end. So here's one. Did the length of stay of the neonate using Eat, Sleep, Console vary depending on the opiate used prenatally?
So most of our population was methadone exposed, but we have a fair number of buprenorphine exposed now. Our length of stay is pretty short, and so not really. There were some kids who were exposed to buprenorphine who really, we didn't see much signs of withdrawal that we might discharge a little bit earlier, like on day 3. But otherwise, our discharge criteria are, we want to be over the worst of the withdrawal, and we want the baby to be eating well, sleeping well, and consolable, and we want the family to feel confident in going home. And sometimes that is the thing that'll last a few more days, and it's not really their exposure is almost irrelevant for that. So some moms are really ready to go at day 4, and if they're over the worst of it, they'll go at day 4. Others, it might take 8 days before they really feel confident that they can handle it. And so those are the discharge criteria. And since the length of stay is shorter, we don't really see as much with the exposure. I think generally if you have the longer length of stay, the buprenorphine length of stay tend to be a little bit shorter. But we've also seen some pretty severe withdrawal of buprenorphine. So we don't we haven't found much different, but that's just, I think just because everything's shorter.
Okay, and a follow-up on that. Did the opioid used influence the amount of morphine used as well?
No, I mean, we're using so little morphine at this point, so so not really. No, it's all within the margin of error. But we're really, again, we haven't used more than 2 doses in 5 or 6 years, so nobody's getting very much of anything. So there's a lot of studies. The studies looking at the different medication to use and the exposures. Really, with the way that we're doing this, isn't going to have that great an impact.